Today, we're diving into Klinefelter syndrome. It's a genetic condition that, for a lot of men, flies completely under the radar until they try to start a family. We're going to break down the biggest challenges, the cutting-edge treatments, and the really personal journey these patients go on, all based on what the medical experts are telling us. So here's our game plan. We're going to tackle this in 5 parts. First, we'll get into why this condition has such a huge impact on fertility. Then, we'll follow the high-stakes search for sperm and the really tough genetic calls that come after. We'll also explain the balancing act of hormone therapy. And finally, we'll look at the human side of it all, the patient's journey. All right, first up, let's get to the heart of the matter. We're talking about Klinefelter syndrome and its massive connection to fertility. But why is it that it's so often a silent condition until guys are well into adulthood? So this is the first big puzzle for so many couples, right? Why on earth did nobody catch this sooner? Well, the answer is kind of frustrating. It's because the condition is just so good at hiding in plain sight. The reason the diagnosis comes so late is that the symptoms can be incredibly subtle. I mean, a guy might be taller than his friends, but who's going to see that as a medical issue? And other physical signs, well, they're just not things people tend to notice or talk about. So what happens? The diagnosis often lands like a bombshell when a couple starts asking for help with infertility. So what's really going on biologically that causes these fertility problems? Well, it's a progressive issue, and it all boils down to one thing: the ticking clock. See, for men with Klinefelter syndrome, it's not just that their ability to produce sperm is low, it's that it gets worse over time. Production often hits its peak around puberty, and from there, it's a steady decline. That makes age the single most critical factor in this whole journey. And this number, wow, this really paints a stark picture. A recent study just laid it out. For patients over 35, the chance of actually finding sperm with surgery drops to pretty much 0. It's a brutal statistic that just hammers home why finding out early is so important. And that brings us right to our next chapter, the actual search for sperm. This is where patients and their partners face some of the toughest, most emotionally draining decisions of the entire process. The main tool in the toolbox here is a really specialized surgery called microtessy. You can think of it as a microscopic treasure hunt, where surgeons are meticulously searching for these tiny hidden pockets of tissue that might still be producing sperm. But, just finding the sperm is only half the battle. This creates a massive dilemma for couples. When exactly do you do the surgery? The timing of this procedure puts them at a major fork in the road, and each path has some pretty big pros and cons. Okay, so this chart really lays out the tough trade-off. Option 1, you do the surgery before the partner goes through egg retrieval. The good thing, if they find no sperm, you've avoided the huge cost and physical strain of IVF. The bad thing, any sperm they do find might be so fragile it won't survive being frozen. Option 2, do the surgery on the same day as the egg retrieval. This lets you use the freshest sperm possible. But if they find nothing, you've just gone through an entire IVF cycle for, nothing. It's a huge gamble. So, at the end of the day, there is just no easy answer. A doctor's job is to lay out all the risks, but it's the couple that has to sit down and make this incredibly personal call for themselves. Now, let's say the surgery is a success, they find sperm, and an embryo is created. You'd think, phew, the hard part's over, right? Well, not so fast. Another huge layer of complexity pops up at the genetic level, and with it, another round of really difficult decisions. This is where we run into something called a mosaic embryo. So instead of an embryo's cells being all chromosomally normal or all abnormal, you get a mix of both. And that creates this gray area in genetic testing that is just incredibly tricky to navigate. The thought process here gets really complex. There's this theory that some embryos can kind of fix themselves by shoving the abnormal cells to the outer layer, the part that becomes the placenta. That would leave a healthy core to become the baby. The problem is, the genetic test is done on that outer layer, so you can't be 100% sure. Because of that risk, these embryos are labeled restricted use and are really only considered as an absolute last resort. Okay, so moving beyond just fertility, there's the patient's overall health to think about. And that brings us to hormone therapy. And you probably guessed it, this introduces yet another major conflict between what the body needs right now and what the goals are for the future. So here is the central conflict, the real catch-22. Testosterone therapy is absolutely essential for boys and men with Klinefelters. It helps them go through puberty, build muscle, just maintain their general health. But, and this is a huge but, giving the body outside testosterone can basically act like a contraceptive. It tells the testes to just shut everything down, including whatever sperm production might be left. And this timeline just shows how the whole strategy has to adapt as a patient gets older. In infancy, a little localized treatment is totally fine. But during puberty, if there's a delay, therapy is short-term, and it only happens after a serious talk about preserving fertility. Then in adulthood, doctors will often try to use treatments that kickstart the body's own testosterone production to try and keep that natural sperm-making process alive. So, the golden rule, the main thing to take away, is crystal clear. Fertility preservation is not an afterthought. It has to be the very first conversation you have before starting any testosterone therapy, as a teenager or an adult. Banking sperm is really the best insurance policy you can have. Okay, so we've talked about the science, the surgeries, the genetics. But let's finish by looking at the human side of this. What are the real-world roadblocks that stop patients from even getting started with treatment? So even with all these medical options on the table, experts say a lot of guys, when they get this diagnosis, they just stop. They don't immediately jump into treatment. So why is there this pause? Why the hesitation? And as you can see, it really comes down to two massive hurdles: money and the psychological weight of it all. These advanced procedures, we're talking IVF, genetic testing, microtests, they're incredibly expensive. And just as big is the emotional hit of the diagnosis itself. It can bring on shock, anxiety, and a profound sense of uncertainty. You know, this journey is so much more than just a series of doctor's appointments. It's an emotional marathon. Patients really need time to just process the news, to figure out what it all means for their life, and to get their finances ready before they can even think about taking that first step. Which leaves us with this final, really powerful thought. We've seen over and over again that with Klinefelter syndrome, timing is everything, from sperm production declining with age to deciding when to start hormones. So the big question is, how can we, through more awareness, earlier diagnosis, and better support systems, both financial and psychological, how can we completely change the game for future patients and give them a much better shot at the family they've always dreamed of?